state of the HIV epidemic, biological, pharmacological agents are critically important. And behavioral and social science activities are equally important. The integration of the two at this moment in time is something we must pay attention to, because we understand that without both components, pharmacological, biological, and the behavioral and social sciences, we're probably not going to get to a point where we're seeing the optimal outcome for individuals and communities. So this work right now is really important. I want to spend some time talking about intersectionality, talking about the role of social work, and I want to recognize and celebrate the work that we do, but I also want to challenge us to think very critically about why at this moment in time is social work a profession so profoundly needed in the HIV epidemic. I've been doing this work for almost 30 years now. I was all of 3 when I started, and okay, I fibbed, I was actually 3.5. But the reality, I've been doing it for quite a while, and we've seen dynamic changes. I must say that as I look across the globe, and when I look at domestic issues, now, at this moment in time, I must say social work is needed as much now as it ever has been in the HIV epidemic. Our practices, our skills have always been useful, but today, more than ever, they're probably needed. So, I want to talk about a case, because I think a case narrative is a great position and place to start a dialogue that integrates our discussion about the intersectionality, the continuum of care, and who we are as professional social workers in the work that we do. So, pictorially, I'd like to give you Ron. This is Ron. Ron is a 34-year-old African-American man. He recently came into care with his social worker, having had his first meeting. And for the sake of today's discussion, let's call his social worker Darrell. You know, what better name to give the social worker in this particular case? Ron's diagnosis is fairly recent for him. However, the biological indicators suggest that Ron's been infected for a period of time. He has a very high viral load, low T-cell count, and is beginning to manifest some other physical complications associated with HIV and AIDS. Ron is a divorced male. He has not currently a relationship partner, although he does acknowledge that he has had sexual relations with both men and women, and he denies any substance use in terms of injecting drug use, but has used recreational drugs periodically. Ron is a professionally employed man. He does have third-party reimbursement insurance, and he has at least some network of friends and colleagues, because in fact it was his friend who referred him to see Darrell, the social worker at the community agency. So when we look at Ron's situation, Ron is, of course, dealing with the complexities of a new diagnosis for Ron. He's dealing with issues of disclosure, and Darrell, being the good social worker he does, encourages Ron to explore the concept of disclosure and asks Ron to consider the network with whom he's going to disclose, articulating from the literature that we know disclosure is an important component for many individuals in terms of being able to grapple with their diagnostic state. Because of his health insurance and the capacity that he has, Ron and Darrell talk about making sure that his employer and the employment agency that he works with and the insurance company is well situated to support him in the treatment options that he makes. He's referred to a clinic that specializes in the delivery of services to gay and bisexual men in the local environment in which Ron lives. The social worker, Darrell, really explores the issue of being a gay and bisexual man and how that really is something that is not to be ashamed of and something that Ron can integrate in terms of doing his work around his HIV status. In fact, the social worker refers Ron to an LGBT bisexual group that's being run at the clinic. And, he wants to connect him with a provider in his area as quickly as possible, and he gives him the name of some providers and really encourages Ron to follow through. Well, one of the things that the social worker did in transitioning Ron from that first meeting to hopefully the next meeting, he made sure there was a next appointment set up. So 2 weeks later, for the next appointment, Ron didn't show up. The social worker called Ron, got his voicemail message, he emailed him, didn't get a response. 2 weeks went by again. He reached out once again, called him, left messages. Ron didn't get in touch with him. A month passes, a month and a half, 2 months pass. Well, the social worker's plate is starting to get filled up with new clients. And Ron kind of falls between the cracks. Ron doesn't come back. He doesn't hear from Ron. And Ron's case is moved to the side of Darrell's table so that he can take on new cases. He's considered, he failed. Maybe he moved. So he just moves on to the next case. The question on the table is, what happened? What happened in the facilitation of the relationship, or worded differently, what didn't happen in that relationship? How did Ron fall through the cracks? And what were the things that this well-intending social worker didn't bring to the table that may have facilitated Ron's connectedness to the best service available? We'll come back to Ron's scenario at the end of this discussion, but I want to hit on a couple of points that frame the context in which Darrell, the social worker, you, the social worker, our colleagues work today. And that's under the rubric of the National Health Strategy presented here. And those of us who are connected to this, and we've all heard about it, and probably at some level or another, we all know about the National HIV Strategy, comprised of 4 critical components. One component is to really reduce the incidence of HIV burden domestically and globally. That's a critical component. In order to do that, we want to offer the best health care available to individuals and to communities domestically and globally, but certainly beginning with our domestic agenda. We would like to eliminate or reduce significantly the disparities that we see across communities and within sectors and populations, be it geographic or identity-based. And finally, we really want to get to a comprehensive, coordinated response to care that integrates the best of biomedical care, psychosocial care, and community-engaged linkages to service. Those are the 4 pillars of the National HIV Strategy. And as social workers, we know what that means and what the potential is for that. And in our discussion time today, in my presentation, I want to talk about ways in which we as social workers can facilitate achievement of these goals. If you don't know it, and this is a segue, the current HIV czar is a social worker sitting in Washington, Douglas Brooks, and we'll be meeting with him in a few weeks. And he is someone who really gets this, and it's really important for us to make sure we take opportunity to recognize that social work is seen as a pivotal player across the continuum of care. Now, when we talk about the continuum of care in a domestic agenda, recognize and understand that we're not talking about a small population of individuals who are impacted, because anyone who's HIV negative runs the risk of becoming HIV positive, right? If you engage in particular behaviors, or if you are infected through mechanisms that we know are likely to produce an infection. But what we do know significantly in this country is that on any given moment in time across the country, there are 1.2 million people living with HIV at this moment in time. 1.2 million individuals. That number stays at a steady state because we constantly see a new infection rate of about 50 to 60,000 individuals per year. And so despite some of the best biological and community-intended interventions, this steady state produces a background of 1.2 million individuals and potentially larger over the course of time that are living with HIV. So the work that we're doing impacts a lot of individuals. And that national strategy is a framework to help us understand how we move people along a continuum of care to achieve the best outcomes. And when we think about a continuum of care and we think about those 1.2 million people, what we know is that about 86% of that 1.2 million individuals know their HIV status. That means that at least 14% of those infected don't know their HIV status. The literature supports and tells us that if an individual doesn't know his or her HIV status, they're more likely not to come to care because they don't understand why. They're likely to infect other individuals because the literature also says knowing your diagnosis is a helpful strategy to also altering behaviors that put you and others at risk for either acquisition or transmission of HIV. But the point here is that even with the best surveillance that we have, 14% of that 1.2 million don't even know that they're HIV infected. Even knowing that you're HIV infected, consider that 86%, only 80% of the 1.2 million individuals ever get linked to care. So that means at least 20% of those individuals are not being linked to care, who even know they're infected, or maybe some of those who don't know that they're infected. But the point is, 20% of those individuals do not get linked to care. So right away, we have a drop-off point or a drop-out point in this country of individuals who could benefit from the services that we offer. And when we think about people who initially get linked to care, only 40% of the people living with HIV receive regular medical care. Think about it. Only 40% of the individuals who are getting care get regular care. What happens? 1.2 million, 86% know their status, all the way to 40% actually get regular care. And what that means and what that paints a picture of is that only 4 in 10 individuals are getting the HIV medical care that could produce a positive impact on their lived experience. That's a profound number. Only 4 in 10 are in HIV medical care. Only 37% of the individuals living with HIV are getting the prescribed medication. And if you've watched, and many of you do, I know you're really critical analytics and you pay attention to this, the CDC constantly moves the litmus mark, and is that we're encouraged to get people connected to care and to get them into the best biomedical opportunities as early as possible to reduce the long-term consequences of HIV infection. But only 37% of those individuals are getting the prescribed medication that would assist them along this continuum. And then finally, only 30% of the individuals who are known to be HIV positive along that continuum, only 30% achieve optimal outcome. Only 30%. That means 70% of the individuals living with HIV are not getting optimal outcomes across this continuum of care. In a country like ours, in a world context like ours, social work has never been more needed to assist at any strategic point along that continuum. And the work that you do, the work that we do, is vital to producing and supporting a sustained change. That means that only 3 in 10 people get the full benefits of everything that we have to offer, be it biological, pharmacological, or the integration of biological, pharmacological, substance abuse, integrated together. Only 3 in 10 in this country. Now, I want to step back from the big picture and posit something a little bit different for you. Now, imagine an individual like Ron, or like many of the clients you probably see. And we know that in certain groups and in certain places, the epidemic looks different. And so that cascade that I just talked about, The percentages may look different in your community, the number of people diagnosed or not. But let's take another examination of a treatment outcome. An individual who is diagnosed HIV positive at, say, age 20, and critically, we know that this is increasingly becoming an epidemic of younger and younger age groups. An individual diagnosed at age 20 who does not come into care and achieve optimal outcome, and remember, that's 70% of the individuals based on the current outcome or the current data, is only going to live 12 years. 12 years. Stop it. I heard somebody say, think about it. That means we collectively have a short span of not more than 12 years, because if you wait till the 12th year, what's that prognosis and the outcome, right? We can't afford to wait. So maybe we only have 8 years. Maybe we only have 6 years. Maybe we only have 4 years. Maybe we don't have any time. Only 12 years from diagnosis to terminal state and maybe not living beyond the age of 32. That's not a lot of time, is it? I suspect most of us in here are over 12 years of age. I want you to look at this diagram, this scenario, and think about something slightly different. If we were to optimize the biomedical outcomes, and you see here on the diagrams, you've got two lines, one showing an individual who's 20, one showing an individual who's 20 and on treatment and HIV positive, the other HIV negative. If that individual is able to benefit from optimal care and move along the continuum, stay connected to service, and achieve optimal outcomes, look at how similar their life trajectory becomes. And that an individual who's HIV negative, that could be me one day, I mean, at that 79 or 71, let's hope so, with my cane, can live almost as long as someone who's HIV negative in this current moment in time. And who knows what the next generation of biomedical interventions are going to be. But when we think about that cascade, at any point along that cascade, there are opportunities for people to end up like Ron, characterized as falling through the crack, not getting the benefit of optimal care, not being linked to service, not being sustained, not achieving the full benefit. Therefore, we cannot achieve the full age differential that we see here. That is not acceptable. The work of social work has never been more needed than it is today. Now, what happens along the way of that continuum from HIV diagnosis to senior citizenship age? And now that I got my AARP card, senior citizenship has characterized itself differently for me, that's for sure. But what gets in the way along the way of that happening? Well, there's multiple systemic factors that get in the way. We know that, somebody asked me, well, what about personal responsibility? Well, there are individual factors, but I would argue that personal factors are couched and lived in an experience that's contextualized. What I'm saying is that it's not just about personal responsibility, but it's about the integration of multiple system factors. And as social workers, we're trained to understand that and to be able to leverage that knowledge to mobilize systems of care and optimize patient outcome. We have to understand and help others to deepen their understanding of the multiple systemic factors from individual to macro that can impact a client's outcome. And this work is really about social work. And the social work interface with the client is a very important component of what we do. Establishing that rapport, creating a context and environment to help and assist individuals to understand the opportunities out there, mobilizing to make sure that organizational systems are ready to sustain, making sure that policies are responsive and proactive to the needs of individuals who have a plethora of needs on the table, many of which we can address readily, some we can't, but none can be ignored totally because what we find is insignificant. Many of our clients and patients make the priority when they wake up every morning. So the work that we do, I want to characterize it in 3 simple, what I call take-home messages. And if you get nothing else out of the profession today, and I'll put on my teaching hat for a moment, I call them the Wheeler Threes. They all begin with W, and the last one may not be grammatically correct, but it's what do you do, why do you do it, and what difference does it make? At this moment in time, in a competitive environment, where we see sometimes, and unfortunately in too many instances, dollars eroding right when we need them most, social workers have to be able to do these 3 things. To demonstrate what you do. If you think momentarily and metaphorically about a healthcare provider or a system of care that, people have, sometimes professions have tools like stethoscopes and scalpels or think of any kind of a tool that you can. But those tools are known to the profession. They're known by us outside the profession. Ultimately, what we do in social work practice, we are the tool. And to the extent that we are the tool, it is incumbent upon us to be able to articulate what we do when we do the practice of social work. It cannot be left to vague understanding, and it cannot be left to others outside of our profession to define what we do. The why we do it is critical as well, because our professional knowledge is predicated on a rich history of concepts, theories, facts, and integrated knowledge. We didn't just wake up one day and say, I want to be a social worker, at least I hope you didn't, to become a professional social worker. That there is a rich history and knowledge base that undergirds the work we do, and it has to be brought to the table so that there is a demonstrated efficacy, and leads us to the 3rd point. We have to be able to demonstrate in a meaningful way what difference our work makes. If we can't articulate what difference our work makes, then why is anyone else going to pay attention to the power of social work? It's incumbent upon us to do these 3 things, and I ask you to think individually and collectively, what is it that we do, why do we do it, and what difference does it make? Now I want to shift a little bit and talk about this concept of intersectionality, which has taken up a lot of really energized conversation now, and it rightfully so. The issue of intersectionality, emergent from a lot of the literature in feminist theory, and helping us to understand how and why the power of oppression can only be understood when we understand the additive, collective, synergistic effect of intersecting identities, is a critical component. And this has moved across a historical time frame that I want to deconstruct for a few minutes here. And when we talk about the article of Lisa Boleg and others, and she talks about intersectionality, what she really does is ask us to think about a metaphor. Talking in metaphors a bit here, maybe because I like metaphors sometimes, and maybe because I think they're the most useful. The metaphor I'd like for you to think about, I don't know if you like to cook or bake, but I'll use a cooking or baking metaphor. I make a wicked butternut squash soup, but I'm not going to tell you the recipe because this is being taped, so I'll go with a cake. I'm not a big baker, so I'm willing to risk that. But think about a cake. And in Lisa's article, she talks about once you've been blended in a cake, it's never the same. But a cake comprised of, some elements that hold it together, a flour, an egg, a sugar, butter, milk, cream, whatever other wonderful ingredients you put in it. Each of those ingredients holds its own characteristic individually. But when you put all of those ingredients together and put it in the oven, it doesn't come out as milk, egg, or flour or any of those other elements. It comes out as what? Hopefully a cake. It looks totally different than any of the individual components, but put together, that's what makes the cake a cake. Intersectionality is much like that. You can't understand the individual by looking at individual components because the individual components define what that individual component is. And you can't understand, as feminist literature would tell us, the meaning of oppression by looking at individual oppressions until you understand the integratedness of this. So for example, talking with a colleague around this issue recently, I had a discussion and she reminded me in a profound way, we talk about the power of gender in a U.S. society. And we say things, for example, like, who holds more power, men or women? And very often in a society with a glass ceiling, we say men hold more power. But let's ask a different question. What about if you're a black man? Do you hold more power in every instance? That may not necessarily be so in certain environments, in certain circumstances, and particularly in the wake of some of the social unrest that we've seen across the country. That intersectionality is important to understand when we deconstruct and understand and ask critical questions or make assumptions about our client systems. And the activity of intersectionality is comprised of so many different pieces. Our gender orientation, our ability status, our race, our religion, our economic status, our education, all of these kinds of things go together to make that cake that is called us, that's called our client, that's called our patient, that comprises our communities out there. But those components have to be understood in a way that defies the individual approach. And over the course of time, how we have come to understand identity and how we manifest it in our work of professional social work practice emerges through a set of lenses. And one of the early lenses was the colorblind or the race-blind lens that says, I don't see race, I don't see color, it's you and me. I just see a person in the room. Well, look to your left and look to your right. If you don't see the color of that person's hair, the gender of that person, the clothes they're wearing. All of us who were in the gym this morning, and I see several people, put your hands up. I see you. Why were you in the gym if you weren't working to make sure you're noticed and you feel good, right? There's an element about being different that is okay. What is not okay is when we use that in a derogatory or negative way. So the color-blinded approach, the universalistic approach that says I don't see difference doesn't really get us anywhere because difference is something that's out there. It's what you do with the knowledge of that difference that really makes the difference. So evolutionarily, we move from at least the enlightened folk, social workers leading the pack, I hope, move from that no awareness to at least a recognition that constituent components of the person's identity, gender, economics, race, religion, all those kinds of things do exist. But when we approached it in a siloed way, we miss something because what we do is we focus on one element and then step back and focus on another element. I think my moment of realization on this point came when somebody talked about a mole on somebody's face, and that's all they could focus on was the mole. Well, then the person became the mole. And you stopped seeing the person, but you started seeing the mole and referring to the person as the person with the mole. And over again, when we see these kinds of siloed approaches, it is in that moment that we recognize that the siloed approach is an advancement from the no awareness point, but it's an insufficient way of fully understanding the integrated, intersected personalities and attributes of identity. And moving beyond the siloed approach, we actually get into a layered approach and recognizing that the multiple identities coexist at a moment in time and we can take a cross-section, but again, like with the cake metaphor, you still see each of the elements as a distinct component and not as an integrated whole. Which brings us to the intersectionality. An intersected personality and identity is like the cake. It is different than the constituent parts, but requires the constituent parts to be there to fully integrate. And if we don't understand that, we miss something critical, and we kind of go to the 1 + 1 + 1 = not 3. 1 plus 1 plus 1 in an intersected identity is greater than the sum of the individual parts. It really is about something that is reconstituted in a way that requires those parts to be there, that change over time, that are in a dynamic, fluid context, that have to be understood and may only be understood based on the individual that we're sitting across own understanding of those core components for his or her life. It takes time for us to do this work. That we cannot distort who the individual is by selecting out one component and making that the most salient component for the person. So like with the Ron, which component was the most salient was determined by the social worker without asking Ron what was most salient in his life. And in fact, we think about how we as providers, society as a rule, our client systems, the families in which they live, often get faced with the stereotypes. Who's the top? Who's the bottom? Who's HIV positive? Who's butch? Who's the femme? Who's the transgendered? Who's the jock? Who's not? Who's fully employed? Who's the thug on the street? All these labels and terminologies get used in ways that stereotype individuals. And sometimes we get sucked into that kind of trap where we operate with the individual based on our assumptions as opposed to spending that critical time. Now, clearly, no one in this room would ever do that, but think about the cascade again. Think about those moments and opportunities where we miss to move people along that continuum. Think about the HIV-infected person who will only likely live 12 years. We have a short window of time to defy some of these stereotypes, to convince others to move systems, to challenge what is being done to achieve the optimal care. That in order for us to do this work, connecting individuals, connecting the dots in an integrated way is a critical task. And I ask you as a colleague, I ask you as a social worker, I ask you as someone committed to this work to think about what do you do, why do you do it, and what difference does it make in terms of achieving the best outcomes. And exploring the meaning of identity, not just for your clients, not for your patients just, but for yourselves. What are your constituent parts, and how do they come together to make you who you are in doing the work that you do? And this exchange between the client and the patient, you, the worker, and your client system kind of defies sometimes what we all learned in social work school as good social workers: start where the client is. How many people have heard that one? I would say nobody starts where the client is. You start where the client is, where you're capable of being. You are a core component there, and intersectionality of you, intersectionality of the patient coming together at a moment in time has to be considered in this work and this equation, and it's never been needed more now than it has been in HIV work. I want to take some time and focus in on this thing we call social work as a profession. Let's look at our title, social work. Social, interacting, relational, work. Hey, roll up the sleeves, get out of the office sometimes, do work. It is a verb, and I mean it in the big sense. It is not an inertia-based profession. Sitting on your duff is not social work. That we have, thank you. And we are not to be minimized or marginalized for this, and in that, we are often considered the helping profession. Well, I would like to reframe this concept of the helping profession. The helping profession is not a handmaid to the other professions. Without this work, without this help, without systemic change and engagement, you're not going to get the outcomes that you say you want as part of a national strategy. Social work has never been needed more now than it ever has been in HIV work. Given the pharmacological, biomedical advances we have on the table, but the disparate outcomes that we see, and many of you know from your own home communities, if we're not mobilizing social work to assist and help, how will we ever achieve those outcomes? Now is the time for social work at the micro, meso, or macro level of practice. Wherever you are, it's that moment in time. Direct practice, individual work with families, communities, small children, or small groups. Macro practice, downstream solutions, we call them sometimes. Great place to be. We don't do that work in isolation from the context of our organizations. Romance with no finance is a nuisance. Having an organization that cannot sustain itself at a moment in time creates havoc for our clients, and it creates havoc for ourselves. It is essential that we have good management of context and environments to do this work. Social workers are needed at this moment in time to bring the best to their meso-level practice. And ultimately, or maybe it begins with policy and ends with macro, or begins with macro and ends with micro, whichever direction you want to characterize it, macro work, like the national HIV strategy, it's essential. So whether you're working with your city or your state, being engaged, or at the national level, being able to do policy level work is an important component. Making sure that resources for housing and funding are on the table is something that we have to do. Who's going to finance the best of biomedical science over time if there are not policy initiatives helping to shape and direct some of that work? Social work has never been needed more. It's important. So let's come back for just a moment and revisit Ron. Realizing that better opportunities could have been available for Darrell to engage Ron, not assuming some of the things that Darrell may have assumed that Ron maybe he wasn't ready for a gay or bisexual group. Maybe disclosure wasn't his top priority. Maybe the knowledge base that Darrell had about great intervention and using medical intervention wasn't where Ron was on that day. Taking the time to understand and explore that could have facilitated a more optimal outcome for Ron and not be seen as someone lost to the system or having fallen between the cracks. It could have facilitated a better movement across the continuum of care so that Ron was not one of the 70% who don't get optimal care, but that the number shifts so that we're seeing 70% who do get optimal care, and hopefully one day 100% get optimal care. That would be our goal. And when we think about our real strong points in doing this work, we have to revisit some of the critical assumptions about social work being a helping profession. I would say we are a core helping profession. We are essential to advancing the science that is made available. And while we may not be the individuals in the laboratories creating the biological or the pharmacological agents, those agents just placed on a table don't do clients any good unless they're accessible and can be sustained over time for the client systems. It's important for us to work on engagement and education, and educating not just our clients, but those around us about the necessity for doing this behavioral, psychosocial, and systems level work. It's important for us to focus on quality assurance and guarantees for our practice. The what difference does it make? The calibration of our professional skill set, the ability to measure and document what we as social workers do. It is an important component of where we are in this epidemic if we are going to continue to be as relevant as we should and could be, and will continue to be, I hope, in this epidemic. We have to be active players in this process, and we have to be able to bridge evidence-based practice, which is sometimes characterized as a finished job, and that has to be balanced in professional context with our ability to continuously grow and evolve in evidence-informed sessions and practice. Our evidence-based, our evidence-informed, and our professional knowledge. And on that, I really want to say thank you for giving me time to be with you, for celebrating all that you have done, continue to do and will do. Vince, thank you for making this conference. The team from Gilead and Porcello, thank you so very much. It's my pleasure to be here and continue in this work.